All right. All right, let's get started. So again, this talk is going to be back to the bones, osteoporosis. Today we're very lucky to have our endocrinology department here. Chrissie Hoover. Chrissie is one of our nurse practitioners in diabetes and endocrinology. After obtaining bachelor's degree in both Spanish and nutrition, Chrissie began her medical career as a nutritionist for WIC. She furthered her education with bachelor degrees in nursing and began a 24-year nursing career, which include U.S. Air Force nurse, school nurse, labor and delivery, antepartum, and pediatrics. She entered the nurse practitioner world in 2019 and initially worked in the walk-in clinic until she obtained postgraduate certificate in endocrinology from Duke. She has worked in both diabetes endocrinology at ANTHC, currently exclusively works in endocrinology. In her free time, Chrissie loves to run, hike, ski, and dance. You can often find her dancing to 80s music at one of the local clubs. Ooh. Definitely look for her when you're out. We also very lucky have Dr. Jeff Medland, who's here with us. He graduated from Chicago College of Osteopathic Medicine with 28 years active duty in Army and Air Force, and finished his residency and endocrine fellowship with the military as well. So let's get them started. Okay. All right, thank you. Let me get this all settled. Okay, so yes, today we're going to talk about osteoporosis. And nope, let's try it down here again. Let's try it again. Okay, so the objectives. By the end of today, I am hoping that everybody can tell us what is osteoporosis and what are some risk factors? And we'll do a lot of that with the bingo cards. How to diagnose osteoporosis, and we'll talk about T-scores. Recognizing indications for treatments, and we'll touch on FRAX. And then we're going to talk about some medications that are commonly used for osteoporosis. Interspersed throughout our presentation, we have osteoporosis risk factor bingo with Dr. Medland. So if you've, everybody should have a card. If you don't have a card, a bingo card, raise your hand and Christy can bring one to you. When he calls out the risk factor, use your dabber, dab it on the card. If you get a line, whether it's horizontal, vertical, diagonal, yell out bingo. And we have a whole bunch of prizes in the front. We've got a bunch of ANTHC merch. We've got bone earrings. And so the first 5 people to win will get to come up and pick a prize. Okay, Dr. Medland, you want to start by picking?
Aging.
Okay. In order to understand osteoporosis, we have to understand what healthy bone is. Healthy bone is not solid like a piece of metal. It actually has bases in it so that we can get nutrients and waste to and from the bones. It's also a matrix. So I don't know if you can see this, but it's sort of like scaffolding to a building. And that matrix is made out of protein, collagen. And then we have minerals, calcium and phosphorus, that are dispersed in the matrix that gives it its firmness and its hardness. The other important thing to remember with bone is that the cells are in constant change. The osteoblasts are constantly building bone, and the osteoclasts are constantly breaking down or cleaving. And that's how I remember them. Blasts build, clasts cleave. Oh, oops, hold on, let me go back. So if you look over to the side, you can see the image of the bone.
The trabecular bone is also called spongy bone. And the compact bone, that sort of encircles it, and that's also called cortical bone. So sometimes the breakdown happens faster than the buildup, and we end up losing bone density, and that is osteoporosis. So exactly what are the definitions of osteoporosis? Osteoporosis is a skeletal disorder of less bone strength. It's progressive and silent. It doesn't just happen overnight. It's slow over time. People don't have bone pain or joint pain from osteoporosis. And the big deal is the bones aren't as strong, their quality is not as good, and so people are at risk for fracture. So if you look on the right side, that's normal bone. You can see the nice big rim of cortical and then the spongy bone in the middle. As compared to osteoporosis, how the cortical bone is thinner and weaker and the spongy bone is breaking down. I love to show patients this image because sometimes since they don't feel it, they have a hard time taking it seriously. So the normal bone, you can see that it's got nice structure, and osteoporosis can actually get that bad. Here's another good picture of osteoporosis. On the right, you can see that it's got good structure, and on the left, it almost looks like you can blow on it and it's going to fall over. And now, some risk factor bingo. Stay alert, stay alert.
Low dietary calcium intake. Low dietary calcium intake.
Okay, so what's wrong with a broken bone? I mean, we've all, well, maybe not all, but a lot of us have fractured a bone riding our bikes or something when we were a kid. You wear the cast and then it's over. Well, as we get older, fractures become a much bigger deal. 60% of people will not regain their functionality after a fracture. They can drastically reduce quality of life. Studies have shown that 25% of people after they have a hip fracture will not survive 1 year. And, you know, just for kicks and giggles, I did a Google search on heart attacks, and the NIH quoted 10 to 12% will not survive a year after a heart attack. And I saw up to 20% will not survive a year after a heart attack. Yet we've got broken hip that's 25%. So we really need to take it seriously. It's a significant disease. So how do we know what state our bones are in? This is a DEXA scan machine, and it will check bone density in the forearm. Sometimes we do that, but most of the time we do hips, spine, and femoral neck. The big thing to remember, well, we use the DEXA scan. There are other methods of checking bone density, but right now DEXA scan is the treatment, is the test of choice. It's got high precision, low radiation. The big thing about DEXA scan is you want to use the same machine. If you're going to compare two readings, you want to, they should always go to the same machine. So who do we test? We don't just screen everybody. According to the American College of Endocrinology, anybody who's had a fragility fracture. So what's a fragility fracture? You're standing, you fall, you break a hip, you break an arm. That's a fragility fracture. So if anybody's had, a very low impact fracture, they should get a DEXA scan. Women over the age of 65, men over the age of 70. If they have significant risk factors, glucocorticoid use, steroid use is a big risk factor for osteoporosis. But a lot of tobacco use, alcohol, and we'll go over more in the risk factors. It's on your card, and Dr. Medland. So how are the DEXA scans measured? The way DEXA scans are measured are with T-scores. And so we interpret it by, we look at the max bone density that a person has, and that's between the ages of 20 and 30. And then it's all downhill from there. So after 20 and 30, we all start losing our bone. And so -1 to 1, I could actually point, but 0 is when you're like 20 or 30. And then as you lose bone density, your score goes lower. So -2.5 is osteoporosis. In this one, you can see a different image to progressing osteoporosis, and it shows -2.5 to -4, but we've actually seen bone densities lower than -5. We had a -5.5, I think, come through this past 6 months. So the official definition is T-score less than 2.5 or a low impact fracture. Again, standing, the force of a standing position. Now, this doesn't include fingers, toes, nose, tiny little bones. It's a significant bone. They fall and they break it. And with that, let's take a bingo break.
Chronic glucocorticoid use. Chronic glucocorticoid use. By the way, it's on there twice. That's my peripheral today.
So why do some people get osteoporosis and others don't? Well, these are our risk factors, and there are a lot of them, and we won't have time to go through all of them. But some of the big takeaways is estrogen, testosterone, those are bone protective. Hence, after menopause, bone loss increases. Gender, genetics, tobacco use. Then we've got medications. A lot of medications will actually increase your risk of osteoporosis. We've got our endocrinology disorders and diabetes. So why are we talking about osteoporosis in a diabetes convention or conference? People with diabetes actually have higher risk with osteoporosis. Their fractures have delayed healing, higher mortality rate, longer recovery. And people with diabetes actually have a 34% increased fracture risk compared to those without diabetes. But interestingly enough, people with diabetes actually have more bone density. They have been found to have 5 to 10% more bone density than those without diabetes. So what's going on? Well, the bones are not as strong. They have impaired microtexture and accelerated bone loss. So it's been proposed that we take the T-score of somebody with diabetes and we lower it by 5. So for example, if their T-score is -2.1, that would put them in osteopenia range, but we lower that by 0.5, and now it's -2.6, and they have osteoporosis. So glycemic management also impacts fracture risk. Studies have shown that if somebody has an A1C of 9% or more for 2 years or greater, it increases your fracture risk by 29%. And that's the big thing. It's fractures, and that we want to prevent the fractures. So with that, Dr. Medland.
Lack of physical activity. Lack of physical activity.
Okay, so that moves us on to prevention and non-pharmacological treatment. We always want to prevent rather than treat. And osteoporosis prevention starts with diet and supplementation. Bones cannot build without material. Calcium and phosphorus are essential for bones to build. So dietary calcium is the first choice. But, some of these remote villages, a gallon of milk is like $10. So, people can't afford that. 16. I mean, and what about lactose intolerant people who can't get milk in their diet? So supplementation is definitely a role. So there's some important things to remember with calcium supplementation. First, you cannot absorb more than 5 to 600 milligrams of elemental calcium in a sitting. So if they've been prescribed, 2 tablets daily, it really needs to be just divided out. It needs to be, one with meals and one with another meal. Calcium carbonate cannot be absorbed without acid. So that's why calcium carbonate needs to be taken with food. If they have GERD and are taking Prilosec, which reduces stomach acid, or perhaps they've had bariatric surgery and they don't have a stomach or don't have a whole stomach, well then calcium citrate's an option. It's not absorbed as much, but it can be taken without food. Vitamin D. Vitamin D is needed to absorb calcium, period. In my opinion, everybody in Alaska should be on vitamin D. If we lived in Arizona, different story. But our sun, you just need so many hours in our sun to get vitamin D. It's just really difficult, especially in the winter. Protein. So we talked about that scaffolding, and it's made of protein, collagen. And so people do need a high protein diet if they're going to prevent or try and treat osteopenia without medications. And caffeine. So caffeine interferes with the absorption of calcium. And so I had this patient, he had chronically low calcium. So I asked him, I'm like, well, what do you drink during the day? And this guy just sipped coffee all day long. So he wasn't getting the calcium absorbed that he was getting through his diet. He was taking his calcium tablets with coffee. So really try and limit to 1 to 2 cups a day and in the morning and not with your meals. Exercise. Bones density will increase with weight-bearing exercise. And I'm not talking about lifting a 5-pound weight. You've got to stress the bones. So the hopping study is actually a really interesting study. They did this in England, and they did DEXA scans. So they checked the bone density in this group of women and in both their hips. And then they had them hop 50 times a day on one leg for 6 weeks. And then they rechecked the bone density, and it had increased in the side they hopped on. Yeah. So, and that's that stress on the bones. Weight vest is another option to try and put more stress on the bones. In Anchorage, we have something called OsteoStrong. So for patients that can afford it, but what they do is they use Nautilus type equipment that focuses on the bone, and it puts the stress on the bone. And we've had patients that have actually increased their bone density using OsteoStrong. And ACE always recommends exercise. Bingo break, Dr. Medland.
Excessive alcohol. Excessive alcohol.
No bingos yet, huh? Okay. So that was timely because the 2 most important things that people can do themselves to decrease is stop smoking. The American Academy of Orthopedic Surgeons have stated that tobacco use will increase the risk of a hip fracture to 30 to 40%. Alcohol is another thing. Alcohol use increases fall risk, and that's the goal, no fractures. It decreases bone formation, and liver disease can affect your vitamin D levels. And like I said, falls are how people fracture. 95% of hip fractures are due to falls. So a lot of this is going to be education with your family. Teach them, people who are on insulin or sulfonylureas who are risk for hypoglycemic episodes. Let's teach them the rule of 15s. How do you treat it? And how about we sit down if we have a hypoglycemic episode while we wait the time out and while we treat it? Additionally, let's do risk assessments on our patients. So are they at risk to fall? Educate people, or if you have the opportunities for home visits, are there cords going across the floor that grandma could trip on? Or are there loose mats that don't have skid on the bottom? Encourage sturdy, low-heeled shoes. Walkers, canes, provide assistance for people that need it. Shoes with good grip and ice grippers, because I can't tell you how many patients we've seen because they've broken a bone slipping on the ice in the winter. It happens so much. And finally, encourage strength and balance exercises. Yoga is really good, and exercises that will strengthen that core so that they can control themselves easier and reduce their fall risk. So let's consider osteoporosis when we're choosing our diabetes medications as well. So TZDs, the pioglitazone, Actos, it will worsen osteoporosis. Also, diabetes medication that could lead to dizziness, hypoglycemic episodes. Some people need insulin, yes. Some people need the sulfonylureas, yes. But if there's a different option, and we can get them off of the insulin sooner, that would be better, especially if they are at risk for, if they have low bone density. And so also other medications can put people at increased risk for osteoporosis, such as glucocorticoids, huge osteoporosis risk for somebody who's on chronic glucocorticoids. Even knee injections, those can affect your bones. And protein pump inhibitors, the Prilosec that decreases acid in your stomach, that will affect the calcium absorption. And it's time for bingo.
Tobacco. Tobacco.
Why don't we do two? Let's do another one, because we haven't had a winner.
Late menses. Late menses.
So you can go up and pick a prize. They're right on the same table, Dr. Medland. Oh, we have two. Yes. Oh, three. Wow. Oh, we used all the cards. Okay. Yeah, we only had 30 different copies of the bingo cards. So. Okay, I'm going to move on. Pharmacological treatment. So even if you're not a prescriber, pay attention to this because there are some things here that you can help with. But before we start, who do we treat? Who should get medications? What? Oh. Definitely anybody with osteoporosis qualifies for medications. Somebody with a FRAX score, which we're going to go into, a high, it tells of our risk. So if they have a fracture risk over 10 years for a hip fracture, that's 3% or higher, or if their risk for a major osteoporotic fracture over the next 10 years, 20% or higher, then they qualify for treatment for osteoporosis. So how do we determine? Welcome to FRAX. So FRAX is a risk assessment tool. You can find it online. You basically just fill in, answer all the questions, and it spits out their risk for a fracture on that bottom corner there. You'll get the FRAX score on the DEXA scans when you get the results back, but I encourage people to do their own because the radiologists, they have so many things to read and they don't always have the complete history for FRAX, for their fractures, and they may not have the complete story. It takes into all these accounts, and we recommend, oh yeah, for rheumatoid arthritis, we don't have diabetes on here. And so rheumatoid arthritis is another inflammatory condition. So what we will do, and it's recommended, is we check diabetes instead of rheumatoid arthritis when we're completing FRAX. Maybe one day they will actually add it, but for now, we just do that. Dr. Medland, I think we have a couple more prizes, right? Yes, so FRAX is only for people who have not been on bisphosphonates. But, the whole point is to determine who we should treat. If they're already on, a medication for osteoporosis. Well, Frax is only to determine who we should treat. They're already being treated.
Celiac disease. Celiac disease.
Okay. I think you got another bingo before we're done.
Low testosterone.
Okay. Okay. Do we have how many prizes do we have left? 3 prizes. So go on up. Go grab a prize. Oh, so we're out of prizes now.
We got 3.
We have 3. But we can still play. You can get the satisfaction of yelling bingo. Huh? Yeah, you can yell bingo. Okay, so first line osteoporosis medication is bisphosphonates. So let's talk about how it works. It is an anti-resorptive. So what that means, it slows bone breakdown, and it does it by acting on the osteoclasts. Remember, osteoclasts cleave the minerals off of the bone. So by destroying those, now the osteoblasts can build more bone. There are some things to remember with bisphosphonates. They have to have kidney function, good kidney function. So if their GFR, estimated glomerular filtration rate, is less than 35, we don't recommend these. Osteonecrosis of the jaw. Now, this risk is low. So with an oral bisphosphonate, it's 1 in 10,000 will get it. With an IV bisphosphonate reclassed, it's 1 in 1,000. But why take the risk? We like all our patients to have dental clearance before we start them on a bisphosphonate. And so that's something you can do. If you're in your village and you're like, oh, they're going to need treatment, get them to the dentist. And it's one of our biggest struggles is waiting for dental clearance.
For cancer, we're usually okay for the
Yeah. It's worse with the higher doses for cancer. They give it like instead of annually, they do it like every month. And okay, moving on. So the other risk is atypical femur fractures. So use of a bisphosphonate for more than 3 to 5 years puts them at risk for an atypical femur fracture. However, we still, in some cases, will take the risk. It's risk benefit with everything. And so sometimes we will extend more than 5 years, but in general, 3 to 5 years, and then we give a 2-year holiday. Hypocalcemia. Okay, well, think about it. We are now putting calcium into the bones. We're stopping the osteoclasts, which would put calcium into the blood, and we're forcing it into the bones, encouraging it into the bones. So serum calcium levels can drop. So they need to be getting adequate calcium either in their diet or with supplementation. This isn't necessarily a risk factor, but I didn't want to forget to talk about it. So oral bisphosphonates, there's a little bit of a challenge to take. They take it once a week on an empty stomach. You can't lay down for 30 minutes after you take it. And it increases the risk of GERD. So if somebody already has moderate to severe, reflux, then oral might be tough for them to take, and it could increase their risk of esophagitis. We don't prescribe it in premenopausal women. It's really bad. It's not like a black box warning, but it is really bad in pregnancy. And I know people say, oh, I'm on birth control. I have had a lot of people say I'm on birth control and then they get pregnant. And you don't want to get pregnant on a bisphosphonate. So we avoid in premenopausal women. But what are the benefits of it? So studies have shown that there are a lot of benefits, and I couldn't cite all the different studies, but in the Horizon trial, it decreased risk of death following a hip fracture by 30%. Next medication is denosumab, and this is Prolia. Prolia works on something called the rankle ligand. So what this ligand does, it's a protein that activates, again, those osteoclasts that cleave the calcium from the bone. So by inhibiting it, now we are inhibiting some of the activation of these bones, these breakdown cells. It has, side effects and risks. Again, the osteonecrosis of the jaw, the atypical femur fractures are risk, but rare. The biggest deal with denosumab or Prolia is easier to say, and why you guys probably don't see it prescribed very often is it has to be given every 6 months. It's an in-clinic injection. And if they don't get it, within 2 months, they start actually losing bone loss or losing bone density. And so it's got to be a very particular patient who doesn't no-show and can get to a clinic that can administer it, who this is good for. Benefits, good benefits, huge reduction in spinal fractures, 28% reduction in non-vertebral fractures, and hip fractures by 40%. Let's play anyway, even though we're out of prizes.
Chronic PPI use.
Yay, we got a bingo. Okay, we're moving on to our anabolic agents. So these are great agents. They actually build bone. So the first one we're going to talk about is teriparatide. Forteo or Tymlos is a different brand. So how does it work? Well, this is actually sort of cool. Parathyroid hormone, the role of parathyroid hormone is to take calcium from the bones. However, they have found that if we spike the parathyroid hormone and then let it go down, it will actually build bone. And so Forteo is a parathyroid hormone analog, and it will actually spike it. It's a daily injection, and then it comes down and it stimulates osteoblastic activity. Benefits, big benefits, 65, 69% in non-vertebral fractures. There are no risk of osteonecrosis of the jaw. I had a patient, I put her on Forteo. She had broken 2 bones in like 3 months. We started her on Forteo. Her teeth were falling out. They just kept falling out of her mouth. So we started her on Forteo. And after that, she never lost, her teeth stopped falling out. She never broke another bone. The big thing with this agent and the next one is you do need to seal it in. So after we're done with this, we follow with a bisphosphonate or Prolia, because they do need to seal it in or they will lose bone that they've gained. Indication. So small group of people that it's covered by insurance and that we recommend it. So if they've had a fracture history, then yes, we can do Forteo. Steroid-related osteoporosis. And, we've also used it for super severe osteoporosis. There are some black box warnings. So think about it. We talked about parathyroid hormone. If it's in chronically elevated levels, parathyroid hormone actually takes calcium from the bones. This isn't going to help if they've got hyperparathyroidism, number 3, because hyperparathyroidism, you've got chronically elevated parathyroid hormone. This isn't going to work, and it's just going to make their hormone level higher. Osteosarcoma was seen in rats. There was a black box warning against if they've had bone cancer, radiation. And because of this, initially, you could only use the Forteo for 2 years, but they've lifted that black box warning. I'm still really careful if anybody's had bone cancer or external beam radiation. Moving on to our next anabolic is Evenity. So Evenity operates on something called sclerostin. And so this is a monoclonal antibody, and it inhibits the action of sclerostin. So sclerostin, oops, that's too fast. Sclerostin does a couple things. It's one of the mechanisms that our body uses to balance the bone so that we don't make too much bone. And so it inhibits the osteoblasts, and it activates the osteoclasts. So by stopping sclerostin, we allow the osteoblasts to function more, and we activate less osteoclasts. So this, in contrast to the Forteo, this not only acts on the osteoblasts to build bone, it also inhibits the breakdown of bone. So it is dual action. Benefits, great benefits, 75% lower risk of vertebral fractures. You can use it if they've had external beam radiation. It's okay if they've had elevated parathyroid hormone. Important considerations, especially for our population, is that it is a monthly injection for 1 year. There is the risk of osteonecrosis of the jaw. And the big deal is, so it's got some great benefits, but studies have shown it does carry increased risk of heart attack, stroke, and cardiovascular death. So we don't use this one as often. The FDA recommends that they've had no events within a year. But there are providers, we just went to a dinner, and there are providers that do use this quite a bit. I just personally have never used it. Bingo.
Postmenopause. Postmenopause.
It's so funny how these bingo cards have been lining up, because our next one is selective estrogen receptor modulators, which is focusing on estrogen. So this is raloxifene. So how does this work? We have talked that estrogen is bone protective. So the people that came up with this medication said, let's monopolize on that. And so raloxifene will have estrogen protective qualities in some tissues and then not in others. So it mimics estrogen in bone and liver. So bone will build, liver LDLs will actually decrease. It's going to block estrogen in uterus and in breast. So we decrease our risks of uterine cancer and breast cancer. So we see 50% reduction of new vertebral fractures, 30% reduction of hip fractures, less breast cancer, lower LDLs. It sounds like it's a great drug, but with estrogen, we also get an increased risk of blood clots. And so it significantly increases DVT, and with that pulmonary embolism, and so increased risk of fatal stroke. So you really need, again, with this one, to be careful who you start with it. So in summary, we have talked about osteoporosis. What is it? We've talked about risk factors. We've talked about how to diagnose it. We've talked about DEXA scan and T-scores. When to treat it based on our T-scores and fracture history, and we've talked about fracs, and we've talked about different medications. And remember, catch it early, treat it wisely, help your patients stay on their feet. Thank you. So we can take do we have time for questions? If we have any questions, and that's why I have my helper. Right there. Oh, yeah, we can pass the mic. Yeah.
So I have a friend who's been on Prolia for like 10 years. Is there any benefit of
So the question is, she has a friend who's been on Prolia for 10 years, and is there any benefit to taking them off of one drug and putting them on another? My first question would be, how is her bones doing? Has she improved her bone density? If she's in the osteopenic range, and she theoretically could transition from Prolia to a bisphosphonate and then get off medications. Because once you're on Prolia, you have to continue it every 6 months. Do you have anything to add?
Boy, stop Prolia, you'll see bone loss within 6 months. By a year, you're back to base. Okay. We also know, and Prolia is good for people with chronic kidney disease. That's why we use it. It looks like Evenity we might be able to use in people with lower renal function. But see, the thing is, the longer you've been on Prolia, that potentially can increase your risk for vertebral fractures too. So it's a slippery slope because you take them off, they're going to go right back.
They would
to
have to
baseline.
transition.
But we keep them on it chronically. That's got some potential negative benefits. Unfortunately, the only drug we can put people on after Prolia denosumab is a bisphosphonate. That's the only drug. The anabolic agents are actually counterproductive. So the only drug we can give following denosumab Prolia is a bisphosphonate. Okay?
Yeah.
But yeah, that's a slippery slope because you can't get them off it, but then long-term use could be counterproductive too. But just not as bad as if you'd stop the drug.
Any other questions? Right here in the front.
Okay, my question is about calcium.
Okay.
At a certain age, we stop building bone, correct? So we need calcium. It's important for muscles and lots of other things. But when you say calcium, are you talking more than the RDA or just adequate?
The RDA actually has an age-based recommendation. And so I always tell my patients who have osteoporosis 1,200 milligrams of elemental calcium a day. We don't stop building bones after. We just lose that bone protective mechanism from the estrogen. So, but people, as we age, we should have calcium in it. We need calcium because we have to help support our bones as much as possible.
Okay.
So,
maximum bone density by age
30.
So after that, everything is just trying to protect what you've got. Because when you hit
Right.
menopause, you can lose 20 to 30% of your bone density. Now you're right. Calcium is very important for many things. Our muscles work because of calcium. Our neurons fire because of calcium. A lot of cellular processes work because of calcium. And so we still push all that calcium and vitamin D because I want you getting the calcium in the diet. Because if you're not getting it in the diet, where do you think the body's going to pull it from? The bones.
Exactly.
And so that's why we want to spare those bones. And so we still say, take that calcium, take that vitamin D, protect those bones, protect what you've already built up. Okay.
Yeah, bones are our biggest storage area of calcium. So.
By the way, can I slip that question? I said, bones. What percentage of your body do you think the bones comprise? Believe it or not, only 14% of our body weight is from bones.
Okay, we have 4 minutes left. So back. Yeah, okay.
I have patients who worry about the calcium risk or coronary risk of calcium supplementation. And so want to avoid a calcium supplement because they're afraid it could increase their ASCVD risk. Is that something you could speak to?
Yes. Honestly, it's best to get calcium in their diet. That's the first choice. That's how it's best absorbed. If they're getting adequate calcium in their diet, we always say go that route because it's best absorbed and it decreases the risk. But if somebody is not getting it in their diet, it's going to pull it into their blood vessels. The parathyroid hormone will pull it into blood vessels anyway, because you need it for muscle contraction and nerve function. So honestly, they need the calcium, and too much, and it's sort of each patient. If they're not getting calcium, they should get supplements. So.
Yeah. Could you talk about the process of stopping the bisphosphonate? After how many years do you recommend stopping, or what the process looks like?
Yeah. So bisphosphonate use after 3 to 5 years, they recommend a 2-year holiday, and then reevaluate if they're if they're in osteopenic range and or normal bone density, then you can take a holiday even longer. But 3 to 5 years for most people, 2-year holiday. And reclassed, it's the same thing, the IV one. So.
Yeah. And just side note, like with bisphosphonates, in this drug holiday, the risk for atypical fractures tends to increase significantly if people have been on it 3 to 4 years compared to 4 to 5 years. So even that 1 year difference makes a difference. The nice thing is Bisphosphonates, they're in the bone and they stay there for years. And so if we want to consider a drug holiday, but say people are still at high risk, what we could do, like say with reclass, instead of giving it every year, we can go every 18 months or every 2 years, because we know that reclass, even after 18 months, we see reduction in fracture risk. And so sometimes for higher risk folks, I'll just continue it, but I'll spread it out the duration. Or I could even give it a lower dose, trying to find that fine line between risk benefit. Okay.
All right. So I think we're going to wrap up here. I know you guys may have lots of questions. Hopefully they'll be around. You guys can approach them. And we do have another talk coming up. Let me just pull it up. And can we give, please, a round of applause for it's hard to get endocrine available. So we are so thankful that they are here with us today. I'm going to move on to the next